podcast. Today, I want to talk about a story that landed in my inbox about a dozen times this month because I know so many of you have asked me about it directly. It's the Stanford study on regrowing knee cartilage. And if you're one of the people listening to this who has, been told by an orthopedic surgeon that you are bone on bone, and you've got, or maybe you've got a hip that grinds every time you stand up, right? I want you to actually listen to this whole episode because I'm going to walk you through exactly what this research found, what it doesn't mean yet, and what you can actually do with this information right now, while the science still catches up. So let's start with why this matters so much. Osteoarthritis affects roughly it's 1 in 5 adults in the United States. That's not a small number. That is tens of millions of people living with joint pain that limits how they move through their day, and it costs the healthcare system around $65 billion a year. $65 billion a year in direct care. For decades, the entire approach to this disease has been about managing symptoms: anti-inflammatories, cortisone injections, physical therapy, and eventually, for a lot of people, a joint replacement. And nobody has had a drug that goes after the actual root cause, which is the cartilage itself breaking down and not coming back. That is the part that makes this new research different. And it's the part I want to share about this new discovery. So I'm not a physician or an orthopedic surgeon, but I am someone who has spent years working with people on the metabolic and inflammatory side of joint health as a certified fasting coach and certified functional nutrition coach who reads a lot of research that crosses over between longevity science and everyday chronic pain. My job on this episode isn't to replace your orthopedic surgeon or your rheumatologist. It's to translate a dense, published scientific paper into something you can actually use in a conversation with your own doctor, and to separate the real signal here from the hype that inevitably follows a headline like this one. So the study came out from Stanford Medicine, led by two research doctors, Helen Blau, who directs the Baxter Laboratory for stem cell biology, and Dr. Nidhi Bhutani, an associate professor of orthopedic surgery. Their paper was published in the journal Science, which is one of the most rigorous, most respected journals in the world. And this is not a press release dressed up as, science. This went through serious peer review. So here's the setup. There's a protein in our bodies called 15-PGDH. You'll hear me call it PGDH for short. So this protein rises as we age, and it has already been linked in earlier work by this same team to age-related muscle loss. And when they block this protein in older mice, muscle mass and endurance actually improved. When they forced young, healthy mice to overproduce it, those mice actually muscles got weaker. So they already knew this protein was a kind of master aging switch in muscle tissue. What they didn't know yet was whether it played the same role in joints. So they tested it. They took older mice with naturally thinning knee cartilage, the kind of wear and tear that happens simply from getting older, and they gave them a small molecule drug that blocks PGDH. They tried it two ways: injected it into the abdomen and injected it directly into the joint. And in both cases, whether injected into the abdomen or injected directly into the joint, the thinning cartilage in these older mice began to thicken again across the entire joint surface. Dr. Blow has said publicly that her team was genuinely amazed by how much regeneration they saw. But here's the detail that really matters if you know anything about cartilage repair, because it is the single most important scientific detail in this whole story. The cartilage that grew back was hyaline cartilage. That is the smooth glassy, load-bearing cartilage that is supposed to be cushioning your knees and your hips. It's not the same fibrocartilage, which is the tougher, more scar tissue like material your body sometimes forms when it patches an injury. Fibrocartilage is kind of like a band-aid, right? Hyaline cartilage is the real thing. Getting your body to regenerate actual hyaline cartilage rather than just scar tissue has been one of the biggest unsolved problems in orthopedics for a very long time. This is what makes this different from a lot of the regenerative medicine claims you've probably heard before. They didn't stop with naturally aging mice either. They also tested mice with injuries that mimic an ACL tear. That's the kind of joint trauma that is incredibly common in athletes and in weekend warriors, and that we know very often leads to arthritis down the road, even in young people. And in those injured mice, repeated injections of the PGDH blocker significantly reduce the likelihood that arthritis would develop after the injury in the first place. So this isn't just a treatment for wear and tear that already happened. It may also be a way to prevent arthritis before it starts in someone who has just torn a ligament or had a serious joint injury. And then there's the part of the study that I think should give real hope to the people listening who are already dealing with like severe arthritis. The researchers got their hands on human cartilage, not from a lab grown sample, but actual tissue removed during knee replacement surgeries and from real patients who were bone on bone. Now, that tissue included both the cartilage cells themselves, called chondrocytes, and the surrounding matrix, the scaffolding those cells sit in. And when they exposed this human tissue to the same treatment, it began producing new functional cartilage. This is the detail that moves a story from this is interesting in mice to this might actually be relevant to a human knee that looks like yours. I also want to specifically address the hip pain side of this because a lot of the coverage of this study talks almost exclusively about knees. And I don't want anyone with hip arthritis to feel like this conversation doesn't apply to them. Hip cartilage and knee cartilage are both hyaline cartilage, the same category of tissue made by the same type of cell, the chondrocyte. The biology of how it breaks down with age and the biology of how this treatment appears to reverse that breakdown is not knee specific. The Stanford team's own language around this describes it as joint cartilage broadly, not just knee cartilage. And their mouse models included general joint tissue analysis, not only knee joints in isolation. So while the headlines you've probably seen focus on knees because knee osteoarthritis is more common and easier to study, there is no biological reason to think a therapy that works on knee chondrocytes wouldn't also work on hip chondrocytes once it's actually developed and tested in a clinical setting. So if anything, hip arthritis patients should be watching this. Research just as closely as knee patients are. I want to spend a minute on the mechanism here because I think it's actually the most exciting part of the story. And it changes how we should think about what regeneration even means. Most of the regenerative medicine world, the stuff you've probably seen advertised at clinics, promising stem cell injections for your knees, is built around the idea that you need to introduce new stem cells to rebuild tissue. That is not what's happening here. So before I keep going, I want to tell you about Larson Nutrition. Joint health doesn't start and end with the joint itself. It starts with what's happening in your gut and your bloodstream, because chronic low-grade inflammation is one of the biggest drivers of cartilage breakdown over time. Larson Nutrition builds their recipes and research around that exact principle, giving your body the recipes and insights it needs to manage inflammation and support tissue repair from the inside out. So if you've been dealing with joint stiffness, swelling, or pain that flares with activity, head over to larsnutrition.com and take a look at the non-inflammatory recipes and blog insights about inflammation. I use these recipes and insights with my own coaching clients. I create these anti-inflammatory recipes and research the insights in the blogs that are much better than what I see in on the shelves in the big box stores. Again, that's larsnutrition.com. Now, what the Stanford team found is that the cartilage producing cells that are already sitting in your joint, the chondrocytes you were born with, do not need to be replaced. They need to be reminded how to behave like young cells again. Dr. Butani has described this as a dramatic shift in perspective about how tissue regeneration can even work. Rather than depending on stem cells migrating in from somewhere else, a huge pool of cells that are already present in your cartilage simply change their gene expression pattern. They stop behaving like old breakdown oriented cells that are chewing through the collagen, and they start behaving like younger cells that build tissue back up. Practically, that matters for a few reasons. First, it means the treatment doesn't require harvesting or growing stem cells outside the body, which is expensive. It's complicated, and part of why a lot of current stem cell therapies for joints are unregulated, inconsistent, and not always backed by strong evidence. Second, it means the therapy could, in theory, be delivered as something much simpler. Dr. Blow has talked with the goal of getting this to patients either as a local injection into the joint or eventually even as an oral medication. An oral version of a related drug with this same research group is already in human clinical trials right now for a different condition, which is age-related muscle weakness. And that trial is testing safety. And Dr. Blow has said it has shown to be safe and effective in healthy volunteers, which is an encouraging sign for how quickly a cartilage-specific trial could move once it's launched. So one more detail worth sharing because it speaks to how seriously this team is taking the path toward real patients. This wasn't a single lab running one experiment and publishing a splashy result. The work was funded through multiple National Institutes of Health grants, along with support from academic foundations focused specifically on stem cell biology and translational medicine, meaning research that's explicitly aimed at moving from the lab bench toward actual clinical use. And the lead authors, Dr. Mamta Singla and Dr. Eugene Wang, worked alongside Blow and Butani across what was which was clearly a multi-year effort, tracking 3 separate experimental models: natural aging, induced injury, and human tissue before publishing. Now, that kind of layered evidence across multiple models is exactly what you want to see before getting excited about a finding like this. So a single mouse study with one outcome measure is easy to dismiss, right? But 3 converging models, including real human tissue, is a lot harder to wave away. So, okay, I know a lot of you listening are not interested in the mouse data for its own sake. You want to know, does this mean I might not need a knee replacement? Does this mean my hip has a chance? So this has not yet been tested in a clinical trial for cartilage regeneration in humans. What it has been tested in humans is a related oral drug for muscle weakness, and the trial showed it was safe. The cartilage-specific human trial has not started yet. As of this recording, Dr. Blow herself has said publicly that her hope is that a similar trial will be launched soon to test the drug's effectiveness on cartilage regeneration specifically. And soon is not a scientific timeline, unfortunately. It could be a year, it could be several years. Clinical trials for a new indication, even with an already tested drug, typically move through phase one safety trials, then phase two for early effectiveness signals, then phase three for the larger trials that actually lead to FDA approval. And that process historically takes years, not months. So if you are bone on bone today and your surgeon is telling you that you need a replacement this year, please listen to that surgeon and don't wait for the drug that does not exist on pharmacy shelves yet. What I'm telling you is that the scientific direction here is genuinely different from anything that's come before it. And it is worth paying attention to because the fact that they got real regeneration, actual human knee replacement tissue, not just mice, is a much bigger deal than most headlines about joint health typically represent. So here's how I think about it. If this were a joint, if you are earlier in the process, meaning you've got moderate arthritis, some joint space narrowing on an X-ray, but you're not yet at that point where a surgeon is recommending replacement. This is exactly the kind of person who benefits most from buying time. Every year that goes by without further cartilage loss is a year closer to the therapy like this potentially becoming available. And that means the things you are already doing or should be doing to protect the cartilage you still have matter more now than ever. Weight management. Get the weight off your joints because every extra pound puts multiple force of pounds, of additional pounds, through your knees or your hips with every step. Strength training around the joint, especially for your knees, your quadriceps, and glutes, because strong muscles absorb load that would otherwise go straight into the joint surface. Managing systemic inflammation through diet and lifestyle. None of that is new advice, but it takes on a different meaning when you think of it as protecting the very tissue that future medicine might be able to help repair. So if you're already bone on bone and a replacement is medically appropriate for you now, I don't want you to feel like you're missing some miracle window. Joint replacement is an incredibly well established, high success rate procedure. It exists because it works. This new research is not a reason to delay necessary care. It is, however, a reason for genuine optimism about the future of orthopedics. And it is worth asking your own doctor if they're tracking this research. Because as more trials get announced, some of you may eventually be candidates to participate. Now let's get practical because I don't want this to just be an interesting science story you nod along and then forget by tomorrow. Here's what the current evidence, separate from the Stanford drug itself, actually supports for protecting the cartilage you have and reducing the inflammatory load in your joints. Number one is movement, but the right kind of movement. Cartilage doesn't have its own blood supply. It gets its nutrients from the fluid inside your joint, and that fluid only circulates when you move the joint through the range of motion. And this is why total rest is often the worst thing for a mildly arthritic joint, and why low impact movement, things like walking, swimming, cycling, and a controlled strength training, tends to be protective rather than damaging. And when you want to avoid what you want to avoid is high impact, repetitive pounding on a joint that's already lost significant cartilage. Things like running on a pavement for long distances if your knees are already bone on bone. Not that most people would do that anyway because you're in so much pain. Number two, strength training around the joint. I mentioned this earlier, but I want to be specific. For knees, that means quadriceps, hamstring strength. For hips, that means glute strength, specifically the glute medius, which stabilizes the pelvis with every step your muscles, weak stabilizing muscles mean more of your body weight gets transmitted directly through the joint surface instead of being absorbed by muscle and tendon. Physical therapists see this constantly. People whose pain improves dramatically, not because their joint changed on an x ray, but because the muscles around it got strong enough to take pressure off of it. Number three, body composition. I know this isn't what anyone wants to hear, but the math here is not optional. Every pound of body weight translates into multiple pounds of additional force through your knee joint and your hip joint with each step you take. And that means even modest sustainable weight loss can meaningfully reduce the mechanical stress on our arthritic joint, independent of anything else you do. Reach out to me if you're trying to lose weight at larsnutrition.com. We got great recipes, great insights in our blog section. And that's what I do is I help my clients through my functional nutrition training to help you guide you through the weight loss. And number four, inflammation through diet. This connects directly to what I do as a fasting coach and a nutrition coach. And I'll do a full separate episode just on fasting protocols and timing soon. So I wouldn't go deep into that today. But broadly, diets high in processed sugar, refined seed oils, and ultra-processed food tend to promote the kind of systemic inflammation that accelerates cartilage breakdown. Diets built around whole foods, adequate protein for tissue repair, and anti-inflammatory fats like omega-3s tend to do the opposite. They help fight the inflammation. Same thing with turmeric, with ginger and black pepper. This is also where time-restricted eating and longer structured fasts can play a role. But by giving your body extended windows without a constant digestive and inflammatory load, and by triggering some of that cellular cleanup processes like autophagy that help clear out damaged material in the cellular level. Number five, and this one is surprising, sleep. Cartilage repair processes, along with basically every other repair process in your body, ramp up during deep sleep. Chronic poor sleep is associated with higher levels of the inflammatory markers that are directly implicated in cartilage breakdown. If you're doing everything else right, but sleeping 5 hours a night, you are working against yourself. Number six, and this is one I don't hear discussed enough, is managing the joints you're not thinking about. A lot of knee and hip arthritis actually gets worse because of compensation patterns. If one hip is weaker or more painful, you shift your gait, and that shift puts new uneven stress on the other hip or other knee, and even your lower back. If you're dealing with arthritis in one joint, it's worth having a physical therapist assess your whole kinetic chain, not just the joint that hurts, because you may be quietly accelerating wear somewhere else without realizing it. I also want to tell you about Larson Botanicals. This is our botanical line built for people who want plant-based support without a lot of filler ingredients or proprietary blends that don't tell you what you're actually getting. All of my blends for organic skincare line, candles, bug balms, deodorants, they have a full label list of what's in them. Because I'm honest about sharing all the organic ingredients that are in there or minerals. And for joint mobility support specifically, we focused on ingredients that real research behind them for reducing inflammation and supporting connective tissue. Things like turmeric extract, boswellia, and collagen, supporting botanicals, castor oil or frankincense or myrrh. These are all very helpful for inflammation. And if you've listened to any of my past episodes on fasting, you already know how much I care about giving the body what it needs to do its own repair work rather than masking symptoms, right? You go to see a doctor, the first thing they're going to do is prescribe you medication because that's what they know to do. And that's the same philosophy behind every product at larsonbotanicals.com. Go check out the joint support collection with the therapeutic myrrh balm. And if you're already a Larson Nutrition customer, you'll find these products complement that line well. That's Larson, botanicals.com. I want to answer a couple of the questions I know are running through people's heads right now. The first one is, can I get this treatment somewhere already, maybe through a regenerative medicine clinic? The answer is no. This specific PGDH blocking drug is not commercially available. It is not FDA approved for any use related to joints. And if you see a clinical advertising something called gyrozyme inhibitor or a PGDH blocker for arthritis, that should raise a red flag because this therapy has not reached that stage of development. Be very cautious of any clinical marketing language that borrows the name of a mechanism from a study like this before it's actually approved, before the product exists. This is a pattern we've seen, unfortunately, before with other promising early research getting misused in marketing. The second question I know people have is, does this mean stem cell injections I've already gotten or been offered at a clinic were pointless? Not necessarily. Existing stem cell and platelet-rich plasma treatments for joints work through different mechanisms, and some patients do report symptom improvement from these shots, even though the evidence for actual cartilage regrowth from those treatments has always been mixed and inconsistent in the research. And what the Stanford findings suggest is that going forward, targeting the cells already represents your joint directly, rather than trying to introduce new cells from outside that may turn out to be more reliable path to real tissue regeneration. Now that's a meaningful shift in how the whole field may approach this problem over the next decade. So I want to zoom out for a minute because the Stanford cartilage study doesn't exist in a vacuum. It's part of a bigger wave of research into what's sometimes called geroscience, the study of the biological mechanisms of aging itself, rather than treating each disease of aging as a separate, unrelated problem. The same protein, PGDH, that this team found drives cartilage loss has also been connected in other research to muscle loss, and there's early evidence that plays a role in how bone, nerve, and blood cells age too. That's actually a really important point. If a single protein turns out to be a shared aging switch across multiple tissue types, then a therapy that blocks it could eventually have implications well beyond just your needs, potentially touching muscle strength, bone density, maybe even your skin, and other markers of physical aging at the same time. Now, that's speculative, to be clear. That is not what this study proved, but it's the direction a lot of this excitement in this field is pointing. The research was funded through the National Institutes of Health, along with several academic foundations. And the team has explicitly said their next goal is to get a clinical trial specifically testing cartilage regeneration off the ground. Now, when that happens, and if early results look anything like what they have seen in the mice and in human tissue samples, this could realistically become one of the biggest shifts in how orthopedic medicine treats osteoarthritis in a generation. Instead of a disease you manage until you eventually need a replacement, it could become a disease you actually treat at the source. I'll also say this because I think it's important context. We have seen exciting mouse studies before that didn't translate into human treatments, or that took a decade or more to reach patients, if they ever did. I'm not telling you this story to sell you false hope. I'm telling you this story because the science itself, published in one of the most credible journals that exists, with human tissue data included, is genuinely a step above a lot of what gets hyped in the joint health space. It deserves your attention, and it deserves cautious, informed optimism rather than either dismissal or blind hype. So here's what I want you to walk away with today. Stanford researchers found that blocking a single aging-related protein caused real functional cartilage, the good kind, to regrow in aging mice, in injured mice, and an actual human knee tissue taken from replacement surgeries. This is a legitimately different kind of finding than most of what gets covered as a joint health breakthrough. It is not available as a treatment yet. There is no clinic who can walk into today. I'm sorry, there's no clinic that you can walk into today and get this. But the direction of the science is pointing at something that could fundamentally change how we treat osteoarthritis rather than just managing it. In the meantime, protect the cartilage you have. Move the joint, don't pound it. Build the muscles around it. Manage your weight and your inflammation through food, proper sleep, and the kind of structured fasting work we'll dig into in a future episode. And if you're already bone on bone and your doctor says it's time for replacement, don't wait on a drug that isn't approved yet. Get the care you need now and keep an eye on this research for what might come next. Now, one last thing before I let you go. I get asked all the time whether stories like this are worth getting excited about or whether it's smarter to, just tune in all about another something and actual sit, all out until something is actually sitting on a pharmacy shelf. My honest answer is that it's worth paying attention in moderation. You don't need to refresh Stanford's press page every week waiting for a trial announcement. But it is worth knowing this research exists. It's worth mentioning to your own doctor next time you're in for a joint related visit. And it's worth understanding the mechanism well enough that if a clinic ever tries to sell an unapproved version of this treatment before it's actually been through trials, you'll know enough to be skeptical. Now, real medical progress almost always moves slower than we want it to, and almost always faster than we expect once it actually arrives. This is one of those stories where I'd rather you hear the accurate patient version from me now than the exaggerated version somewhere else later. So thanks so much for listening. If this episode was helpful or resonated with you or someone that you know that this would help, please share it with someone in your life dealing with joint pain, and they'll thank you for it. And go check out larsonnutrition.com and larsonbotanicals.com for the products that I mentioned today. I'll see you in the next one, and have a great day.